So we go on to the next session, and Dr. Shailesh, Dr. Anita, and Professor Vincent can you be the chairperson. I don't know whether Shailesh is here, but we are changing the sequence a bit because Professor Mario Martinez from Spain has been waiting for a while online. His talks are online. There are two talks of him. One is on fusiform aneurysms, overlapping flow diverter. We want to cover this topic. At times, one flow diverter is not enough. And sadly, when they were printing the session, our printers missed the one session from 12:50 to 1:20 about troubleshooting. So there is another talk by Dr. Mario about migration of FD and challenges in opening tips and tricks. So he will take both the talks, and this will be followed by Dr. Manmohan Singh's talk on bypass surgery. Yeah. So can we have Dr. Mario's talk? I mean, I think that we got. Can we start it?
Hello everyone, welcome to this ANVI Masterclass. First, I would like to thank Dr. Bipul Gupta for the invitation. It's a really honor to be here today about talking about this wonderful topic. I hope you enjoy the presentation, and if you have any talk, we can discuss after all. Well, this is the name of the topic. Is called flow diversion, herniations, or migrations into aneurysm sac. This is important to discuss the types of the migrations and how to solve these terrible complications. There are some technical tips and tricks, and I think that you are going to find it really helpful. That happens to me in some specific cases, and believe me, I spend a terrible time trying to solve. So I think it's very important for us try to share this type of experience in order to minimize the potential mistakes or the potential bad times that you may have by achieving this type of complication. Well, this type of flow diversion herniation could be device prolapse into the aneurysm. So the reality is an underreported complication. Nobody talks about that. There is no descriptions, into the publications, no description into the trials. So the point here is that it's a really potentially devastating technical complications that may finish in an arterial occlusion or may finish in thromboembolic or hemorrhagic complications. There are different causes for having this type of complications, herniations. So first thing is it could be immediate, may happen just immediate after placing the flow diverter. That's called intraprocedural, or may happen into delay fashion. Happens. You need to know that may happens weeks after the implantation, and most of the times is because of foreshortening of the device. Maybe more frequent when you have some arterial mismatch, because some of the artery have proximally or distally they don't have exactly the same diameter, so you may have this arterial mismatch. And what's going to happen is which is called watermelon phenomenon with a foreshortening of the device. Another cause could be iatrogenic. Yourself, after finishing the deployment, you may push the microcatheter into the device and foreshortening and prolapsing this or sending the device in the aneurysm. So you may be the one created this iatrogenic. And another reason could be try to do too much unsheathing during the delivery, and it may happen. This is an example to see that if you unsheath too much in order to increase the length of the device, what may happen after that is going to foreshorten, because the device usually goes to the length that is designed for. So don't try to change the length of the device by unsheathing more or try to pulling back more, to cover more segment, because the stents naturally they are going to foreshorten, and that is called accordion effect. And I think the most typical reason is the incorrect device sizing, because you select a short device. So if we need to understand, there are two different types of device migration. Could be proximal or distal. So imagine this case. This is a proximal artery, for example, proximal ICA, then the aneurysm, then the distal ICA with M1 or A1 here. So if you analyze this and you have this type of, anatomies, you need to differentiate between proximal end and distal end of the device. If you have a distal end, okay, protrusion, we could come benign because it's really easy to solve this type of complications. So the device go back here, you have the device implanted and the device proximal migrated into the aneurysm. So this distal end migration could be easily solved by, renavigating again the system, doing a loop inside the aneurysm. You may do this and then you may, I will show you cases later, don't worry about that. What happened with the main problem is when you have this proximal end migration. When the proximal end goes into the aneurysm, then you have a really problem because we could call malignant, but it's not malignant. It's just to illustrate, this a really complicated way to go through because it's not easy to find a way. Usually the devices bend, turns. This is the natural way. So it's really complicated. You can imagine that you cannot go so easily inside using the microcatheter. I'm going to show you different techniques for trying to regain the access, which is the proximal end. So again, proximal end complicated, distal end more easily to technically manage. Okay, so let's talk first about the easy ones, the distal end herniation. So this is an illustration of the case that I did some years ago. It was a supraclinic aneurysm, saccular, and we initially placed the device here in this point. You see the distal end, and distal end seems okay, but we could say it's a little bit closer to the aneurysm. If I have this case now, I would probably have the distal end here. But anyway, we place the device here in this junction, distal ICA. A patient did really well, but 3 months later, the patient tell us that they have some headache, so we did a CTA. And that's what happened. You see, you have a tremendous distal end migration. You see here the device is completely inside the aneurysm. And this happens because we have this mismatched diameter and we place the device really close to the aneurysm and we place the device in this junction, in this cord. So having this problem, for sure you need to solve and you need to treat it. So how to solve this? Easy. You navigate it through the stent. You have the proximal end open, so it's just go through, do a lumen inside, achieve a distal position. You may do my recommendation with a double lumen balloon. Then you inflate the balloon, and keeping the balloon inflated, you pull back the wire. And by pulling back the wire, what you're going to do is to straighten the system, and you have this flow diverter already into the neck. Once you are there, you may do different maneuvers. One potential thing is you have a double lumen balloon. You may do an exchange maneuver and place another flow diverter and fully cover. So this is the case. You see here the flow diverter, which is completely inside. So what I personally did is navigated this balloon. At that time, I remember it was a scepter, or you may do an Eclipse 2L2. So anyway, we navigated, inflated the balloon, and then we pull the system back to straighten the system, exchange. At that time, we use a Marksman 27 because that's what we have on the shelf. But right now you have different options. And after that, we place the second flow diverter, in this time very distally in M1, and we fully cover everything and do a fully reconstruction of this segment. You see the stagnation here, and now the device are much more stable. Well, let's go into the more complicated migration, which is the proximal end migration, the malignant type. I'm going to show you two cases of this complication. This is the case seems easy at the first impression. It's a supraclinoid. Sorry. So it's a supraclinoid pigment aneurysm, large. So we place the pipeline in distal M1, as you may see here, and then we navigate it more proximally, covering the neck, and you see the proximal end. So my mistake first was to select a very short device, 4x18. Having this case now, I would probably select a 30 or similar. And I tried, because I realized that, I tried to, try to stretch a little bit more and do more unsheathing in order to do this a little bit larger. So this is the maneuver. It seems okay after the finishing the maneuver, but I retrieve everything back. I retrieve the micro and the wire, and I did the run, and this is what happened. So completely proximal end migration inside the aneurysm. So now we have a problem. I presented this in different meetings, and we have different discussions, and nobody had the good answer for, solving this complication. So we tried to regain the access going inside again of the stent, and we spent many hours. I think 3 or 4 hours. It was impossible because the microcatheter always tend to go to this part, because you see this is a typical, weight of the blood inside with this shape, so it's impossible to achieve this curve inside the stent. So we after 3 or 4 hours thinking, okay, we realized that we need to try to move, I don't know how, try to move this proximal end of the stent from this position to this position, and keeping this, then we were able to regain the access. So to move in this, what we thought was to do this maneuver. It seems dangerous, but we did it very gently. So the way is to place the balloon, around the stent, close to the aneurysm lumen, inflate it, the balloon very gently, and at the same time pulling back the wire to avoid overpressure. This is a really risky maneuver. Just you to know, how to do that. So we inflate the balloon, pull back very gently. We change a little bit the position of this proximal end. You see here we have inflate a little bit more. Now we have more angulation, and now it's more easy to regain the access. So we kept the balloon inflated without touching, and then we select another micro wire, and at the same time we navigated through the stem distally. So once we are doing that, and we did it using another balloon, then we inflate the balloon, pull back, and we left the stent at the level of the neck. Once you have the stent at the level of the neck, you see how is the real diameter. So obviously it was a completely wrong decision or device selection. After that, we were able to navigate the microcatheter, just keeping another wire inside for not losing the access, and then we telescope a in this case, 2 additional flow diverters, and we fully cover everything and do a fully reconstruction. This is a really complex maneuver. I realize that. So I give you here what is the publication about that, because we publish it in JNIS. In case you want to review, this technique step by step, everything is well explained here. So I recommend you just to read it. Another case, proximal aneurysm. This is a different type of aneurysm. This is a more dysplastic, more proximal, but may happens too. And in this particular case, the device was good, but we did it so it was really iatrogenic, because we tried to navigate it through the stent to do an angioplasty, because distally they were not fully open, and during this we push the system inside. So it could be, this is iatrogenic, so we need to do exactly the same maneuver. The problem is here that we couldn't go through like the other case. But the good thing is that we have a lot of space around to do different loops, and we can do one loop. After doing one loop inside, we can do exactly the same maneuvers. This is that materials that we use it for navigation. And once we place a distal system distally, sorry, what you can do is open the stent retriever distally instead of the double lumen balloon, as you remember for the other case. In this case, it's an stent retriever, and using the stent retriever, you may pull back the system, straighten the system, and using the same microcatheter, what you may do is placing the flow diverter more distally. So this is the case. It was a giant proximal cavernous case, partly thrombosed, as you may see here. We select the radial approach. It's a really, tortuous anatomy here. And this is the 3D, just to understand how is the shape of this aneurysm. So we tried to open the device. It was a cobalt chromium device, pipeline. Pipeline, the longer length may require more time for distal opening. So we negotiate well. We open more or less. You see here is open, but we still have some stenosis there. That's why we did try to do an angioplasty, and this is what happened after navigation. We push there, so you have now the stent open, but you have the proximal end completely migrated. And the worst thing here is that we have also some clot here because it was partially thrombosed. So we tried to regain the access, and very gently, after several times, what we did is navigating through the clot, very gently. And it was surprising for me because it was really soft and stable for navigating. So we did, I think, 1 or 2 loops. We were inside. Once you arrive and you have the microcatheter in a distal position, then a solitary stent was open in M1, M2. And then we gel everything back for straighten the system, as you may see here, and we straighten all the system back. And through the marksman, we deployed another flow diverter, another pipeline, and then we fully cover all the segment. And you see here how is the total reconstruction of this segment. So my recommendation, the strategy is better to prevent than solve, because obviously these cases happens because of bad technique. So this is an illustration to see that we can avoid this type of complications. You may appreciate here this dysplastic aneurysm in the supraclavian segment with a very short landing zone here. So if your plan is to place the flow diverter in distal ICA, it is okay, but you need to realize that you have a high risk of having a distal end proximal migration. So one of the ways to stabilize the device is placing here, for example, in distal M1, or even here in M1, M2, and then you may have enough space for negotiating, so you have a better landing zone, but you still prefer to having here. The way is to add, for example, coils, and this is one of the recommendations that I'm telling you. If you add coils, you are minimizing the risk of migration. This is the case, obliques view, to understand more or less the morphology. And just to illustrate how we did it, we placed the device. You see here, you have this opening of the device on the aneurysm. We place another microcatheter gel, and after that we place some coils, and the coils allow to fully open the device and prevent the migration and stabilize. So the coils are not for increasing the occlusion rate. The coils are for stabilizing the device and avoiding immediate or delayed migration. This is a nice example to see. You see the device very short landing zone, but they are fully stable because the coils are keeping the device in place. So this is one of my recommendations, to use the coils. So technical tips for take home: proximal end herniation are more dangerous and should be avoided as much as possible. For bailout, always loops, intra-aneurysmal loops are necessary, so you need to be familiar with this type of maneuver. You need to do how undo the loop. For undoing the loop, remember, you may do a double lumen balloon or a stent trigger, or a combination of both right now, so you have the two possibilities. And in conclusion, I give you these conclusions. It's better to avoid than solve. Remember that giant aneurysms are challenging and usually associate arterial tortuosity. Tips to avoid migration: select larger devices, anchor very distally, pay attention on sizing. Sizing is very important. Sometimes we are, very fast and try to, select whatever device. Take your time, do a nice sizing. If you have a free device segment into the aneurysms, be cautious when you are doing an angioplasty, or do have some tendency to foreshorten. Remember that coils may prevent the migration. If you are not sure about landing zone, then telescope a second device. And remember that flow diversion unconstrained into the aneurysm lumen opens to nominal and promote the foreshortening and then the accordion effect. Okay, so thank you very much. This is all about this talk. I hope you like it. If you have any discussion, please let me know. I will be very happy to talk with you. Thank you very much.
Thanks a lot, Mario, to record this. It's a very nice discussion. I mean, overall, you covered all the technical points. And Vincent, so...
No, thank you, Mario, and hello. The presentation is very nice, and the malignant form resolution is impressive. I was wondering if, before doing the technique with the balloon, if you had tried to just try to remove the stain by using a snare, since the flow diverter is floating, so maybe you have a chance to grab it with a snare before just removing it. And before, did you try?
Good morning. Can you hear me? Yeah?
Yes, we can hear you.
Perfect.
Yeah.
Thank you, Vipul. Thank you, Vincent. Yes, we tried several things. We didn't try, at the end to put an instant trigger. We didn't. I mean, or a snare. We thought about that, but placing a snare inside the aneurysm could be an option for sure. It is the first time that I had that complication. Terrible, believe me, was a nightmare for us. But any option is okay. It's a good suggestion. So whatever you have on shelf to try to remove it or change is good. But we didn't try that maneuver. Maybe next time.
Yeah, no, very interesting. And I love your message. And I think it's a very good message that the anchoring zone, the wider the neck is, the longer it has to be. So it should be as long as the neck. If you have like 10 millimeter neck, you should have 10 millimeter, at least 15 meter anchorage. Is the best way to avoid those kind of difficult problem.
I think, yes, the way you mentioned avoidance is the best. Long device, understanding how it will open in the fusiform aneurysm, great anchoring, having enough device proximally so you have to recross angioplasty stable enough was absolutely great. But I think once in a while everybody can dislodge one, so I'm really happy you showed the tips and tricks of the trade, how to, if you have ended up a problem, then how to get out of it. And I really want to thank you for it.